Thank you very much, Sue. So yes, the talk today is about the project we were carrying out, a project funded by the Royal Society of Edinburgh and titled Translating Informed Consent in Scottish Maternity Services. And here are our two universities, Edinburgh Napier University and University of Edinburgh, who gave the support to this project as well. We know informed consent is integral to maternity care, and this consent can be quite often verbal and sometimes written, and it is fundamental to gold standard care and patient safety. And we also know that demographics-wise, 15 to 30% of mothers and birthing people giving birth in any given country are actually born elsewhere. So let's say within the UK environment, up to 30% of mothers giving birth have been born elsewhere, and they are from a different linguistic and cultural background. And informed consent is significantly impacted in situations like this, where the parents are coming with limited English proficiency, which impacts on their ability to understand the information that is given to them, and also with limited health literacy. So it's not only an issue of not being able to speak the language, but even if they can speak a little bit, their health literacy might be limited. And on top of that, of course, they might be not so familiar with the local procedures, administrative procedures, and the customs.
And also what we know is that in terms of trauma, birth trauma, PTSD, and a lot of this links with the intensity of a childbirth experience, which is naturally a very intense bodily experience. But fear, anxiety, uncertainty, lack of trust in the care providers. So if people are not understanding what's being said, if their language is limited, or their understanding of English is limited, then obviously that has an impact on their way of knowing what's going on around them. So this links very closely to some of the trauma that we can see experienced by people. And there are some power differentials as well that are picked up between staff in the institution, but also staff and the woman or the birthing person.
So our study, to our knowledge, it was the first or one of the first to explore informed consent in maternal healthcare from both midwifery and translation studies perspectives. It's quite common that these professionals work together on a day-to-day basis, but they don't necessarily have the time to stop and think about how they work together or what is involved in that working environment. And our objectives were to explore the understanding of informed consent for parents with limited English proficiency by maternity healthcare professionals who request the informed consent from the mothers and birthing people, the translators and interpreters who mediate the informed consent, and also researchers in both disciplines and beyond. We had people coming from medical ethics, medical anthropology, and medical history as well.
So if we think about the maternity healthcare professionals, a lot of the decisions that are made during maternity healthcare have far-reaching consequences, both physically and psychologically for the mother and the baby and ultimately the family. We know, as Sue has pointed out from the Embrace report, there are still very significant inequalities in healthcare provision and in outcomes, with the perinatal outcomes being much poorer for minority ethnic families. And of course, the minority ethnic families, people from Black or Asian background and other cultural backgrounds, are often the families who may not have full level of English. When we're talking about treatments, care in Scotland, obviously we're talking about English being the primary language, but it's not for many, many families.
From the perspective of the translators and interpreters, there is often some tension because they are expected to remain unbiased, objective, and invisible in any given working environment. But of course, when working in a very intimate environment like birth, it's difficult to carry this unbiased and invisible role. They're also not expected to act as advocates for the birthing people they are supporting, even though they may be coming from the same cultural background, same linguistic background, even though they may feel some kind of affinity with the people they are supporting, they are not expected to act as advocates. This can lead to a certain form of apathy, saying, I'm just the interpreter here, I don't need to do anything more than what is demanded of my profession. It can also lead to interpreter burnout. And I know that in midwifery, you talk quite a bit about midwives having the burnout, but interpreters do have it as well. And ultimately can lead to a breakdown of communication between all the parties involved, because interpreter is such a key, in such a key position to ensure that the communication is flowing smoothly. If they decide that, okay, this is not working, then the communication may break down. So in the design of this project, I will just go over this very quickly. We try to put the institutional and professional hierarchies aside. So we opened the workshops and the focus groups we were holding to midwives, midwifery researchers, interpreters, interpreter trainers. We also tried to reach out to obstetricians, and they were quite interested, but for various reasons, they couldn't turn up. So our emphasis was very much about collaboration and exploration. And we tried to ensure that there's cross-professional conversation between these different parties. So we held 2 online focus groups in March, and then in-person interactive workshops in April. And the participants came from, as I said, maternity care professionals, as well as students, and I think they benefited greatly as well. Translators, interpreters, researchers, historians, and ethics researchers in the medical field. On 7th of October, we held a big international colloquium. So this was beyond Scotland, and more than 100 people turned up. That was a very interesting event. They were coming from these various professions, and we had 9 speakers who approached the concept of informed consent from a variety of angles. And currently, we are holding our impact events. Actually, the first one was today. We held a workshop with students at Edinburgh Napier University, particularly on this issue. And we will be writing up 2 articles, one for each discipline, one for midwifery and translation studies as a result of this project. The focus groups were altogether 17 participants, and we had these guiding questions. At which stage of childbirth do most issues arise? What is good practice? What seems to help or hinder this good practice? What do the participants think about the use of technology in interpreting? Because as we know, there's video interpreting, there's telephone interpreting. If the interpreter is not there, we also know that everybody's turning to Google Translate or other apps that can be easily accessible, but may not give satisfactory results. And also we wanted to touch a bit about this difference between legal and ethical aspects of informed consent. So is informed consent just a piece of paper that needs to be signed, or are we making sure that the person in question actually understands what's happening, actually gives the consent, and it's not a matter of just moving on, signing a piece of paper and going, getting on with it. In the workshops, we held together with an Edinburgh-based arts company called Active Inquiry. They were facilitated by this theatre company. And we explored informed consent from perspective of those who mediate for the parents with limited English proficiency and those who offer them care. And exactly like what Sue was saying at the start, it was an opportunity to be in each other's shoes. For instance, a midwife, because the whole thing was about role play. And in these role plays, we gave the participants the option to choose whom they wanted to act. So a midwife could be the interpreter and vice versa, and somebody could be the anesthetist, and a midwife could be the mother or the partner who's supporting the mother. So it gives the people opportunity to see the situation from each other's point of view. We created also, as in this example, you can see on the slide, we creatively represented a child's toy and then discussed how it may be related to informed consent. And we focused on some scenarios. For instance, a charge midwife needs to inform parents that their elective C-section will have to be delayed by a day due to shortage of beds, staff, which may sound quite familiar to some of you. Or an anesthetist recommends an emergency C-section to a couple whose baby is showing signs of distress.
So that was the way we collected the data. And in terms of the analysis, the focus groups were audio recorded and these were transcribed. The workshops were both audio and visual recorded. We had filming, and then we sat and took time to go through and re-watch these and made summary transcriptions and pulled out the key points that were being raised and some of the key information within those. We took the approach of analysis using the qualitative framework analysis. So we've created frameworks for both the focus group data and the workshop data, and then we've collated these and compared and contrasted to pull together the key themes that are coming out from both. And we were really wanting to look at the themes of that lived experience from the perspective both of the healthcare professionals and the interpreters, and pulling as well the information we were having from the historians or the anthropologists, just to enrich the whole picture and understanding. And just that's a little bit of the steps in a framework analysis, just to really become familiar with the data, to really immerse ourselves in reading it and becoming familiar with what was being said, pulling those themes together. Ultimately, we're going to create a conceptual framework, which is still in progress at the moment, and then to maybe apply this framework and review the data. So as I said, we were combining them. So the themes that came up from the focus groups and the workshops were triangulated to bring together. So let's just look at the moment. These are the key themes and sub-themes that have arisen. We're still in the process of writing up this analysis. So as we create that conceptual framework and start to look back and reflect on the data, this might shift slightly, but I think this is definitely the key that we're finding. And so the main themes that were arising were about the resources that exist, and that could be time. As we know, across midwifery, time is such a key resource that's incredibly limited and has all sorts of implications in terms of the quality of care that we can provide. Leaflets, written information, the access to classes, and also the individual's literacy and the materials that might support that. We were looking also, another theme that came up was the quality of the interpreting service. And this could be understanding what the knowledge is of the interpreter, a nuance around language, continuity. We talk about lots about continuity in childbirth, but also that was coming up as a key factor, potentially protective and helpful factor, and that building of trust. And that trust comes between the interpreter and the woman, as well as the interpreter and the healthcare provider. And also looking at, is the interpreter the person themselves? Are they a person, or are they just a tool that has to remain completely disconnected from what's going on? Cultural awareness is a big theme to really sort of look at, and I'm going to explore this a little bit as we go through. But that health literacy in different cultures, the way in which women, birthing people might understand their own bodies, have their own knowledge about what the health means and what childbirth's about, will vary in different cultural settings. So knowing and becoming aware of that, the role of partners and what they might expect to do, and who are seen as the experts. And in different cultures, it can be the midwife, and others it might be the medical professional. So just what is being understood there. And then power. Power is, we've just been talking about bullying. Power is a theme that, is very close to my heart in terms of trauma and in terms of the way in which we provide care. But in this picture, those who have limited English or in a culture that's not their familiar culture, shame, fear, where that location of power sits, and the level of conflict, these were all coming up. So I think if we take those a little bit more, I just want to break those down a little bit more. So if we look at time, we're talking about time to give the information, which takes longer if we're working through an interpreter. So how do we expand and allow that time when it's already restricted, to be able to really listen, to respond, and to check back? We have that lots in our training about check back, that the person has understood. How much can we do that, and how much is it being done? Leaflets, the availability of them, the format they're in. We also had people who talked to us lots about the needs of people who are deaf. So British Sign Language, and for people who are deaf, their first language may not be English. So a written format may not be what they need. Maybe they need something different. And is the information relevant to the local area? Or in some cases, it's been pulled off the internet and it relates to a different cultural, a different maternity setting, for instance, in Australia, which is not relevant. Classes, as we know, we're touching on COVID here a little bit, but a lot of antenatal classes were stopped, cancelled in-face classes. There were online classes, which are helpful for some, but not everybody can access online if they don't have the technology, and often there's a cost. And literacy, again, spoken versus written, or is the first language, is it a dialect, or are we looking at British Sign Language? So I want to pull out some of the key quotes that came up. So one of the midwives had said to us, in terms of resources, we would use anything we can get our hands on. And the lack of face-to-face classes, obviously nobody's fault with COVID and everything. Everybody's sent to online, but it's just really, it's heartbreaking, as one of the interpreters. So that quality of interpreting service, knowledge, training, there's a concern between, often for the healthcare professionals, what's the knowledge of this interpreter? Are they fully trained? And there are questions and there are differences and variations in the level of training or regulation that exists depending on where that interpreter has come from, whether they're in a face-to-face service or on phone service. Are we accessing the correct language? Are we able to get the interpreter that speaks the language for the family that we're working with? And again, that local knowledge. We talked quite a lot about nuance came up, the tone, the emphasis. And again, that's a very cultural thing. The way in which we might use a word. One of the expressions was, the use of the word sorry. In one culture, we might be saying, I'm really sorry about this. In another culture, that might be seen as, well, actually, you only say sorry, something really, really bad is happening. So that would be taken on a whole new level if they were hearing the word sorry come up, and maybe interpreters wouldn't interpret that directly for us. So body language as well, that continuity, are we translating? Can we trust what's happening? Are people being honest? Is there an honesty coming back? And sometimes the woman might, because she maybe has a shared language with the interpreter, may feel more connected in some way and start confiding in the interpreter, and the interpreter's trying to remain distant and make sure that they put that word across. So in terms of the quotes that came up in relation to this, one of the midwives said it's very important to build up a relationship with interpreters. And honestly, in the research I've done about trauma and everything, the talk about build up the trusting relationship between women and midwives, and now we're talking about between midwives and interpreters, it's key across the board. Continuity, again, we hear about continuity, but continuity of interpreter can be really important as well, again, building up that knowledge and trust. And yeah, one of the nuances, I strongly advise, if we're saying that in this culture, we really mean this is as urgent as it gets in English, but in some cultures that might just be taken as a suggestion, or maybe not even a recommendation. And the interpreter may just translate that as I advise something, which loses urgency. So understanding that cultural difference in the way in which we use certain terms. So the third main theme is cultural awareness, and we're still unpacking this quite a lot. But again, that health literacy, cultural knowledge of one's own body, health, expectations. Some women don't, depending on the culture, may not expect that they even have a choice. So we're giving them information, expecting them to make a decision or make a choice, and that might be totally not what they want to do and could be quite alarming. Do partners carry authority? What is happening in terms of the presence of partners, and how does that impact on the woman's ability, and how do we understand what's happening in that culture and in that family grouping? And then who, again, is holding the expert knowledge? And some of the key quotes that arose within this was one of the interpreters was saying that, you do realise where she comes from. She doesn't need to understand this. And that's that health literacy. In their culture, they don't need to know this. They just need to be told A, B, or C. Whereas we might be thinking, no, in order to give informed consent, they need to have an understanding. But that's not where that culture is sitting. And then a key midwife was saying as well, it's just that lack, a wee bit of cultural awareness, a lack of that awareness, which can sometimes lead to conflict in the room, which is upsetting for everybody because their backs are up because things are coming in the wrong way. And the last theme that we're really looking at is power. Shame was a big one, and women will often say to us, I don't need an interpreter, or they'll just nod and say, yes, I know what's happening, and they don't. But they really don't want to show anybody that they don't know because they don't want to be seen as somebody who doesn't understand or isn't knowledgeable about themselves. But there's deeper than that, because if we're looking at refugees or asylum seekers, to show that they don't understand, or to even not agree to understand maybe a different dialect or a majority language from their area, actually might reflect politically quite different, and it might show them up in some way, or they might risk them exposing themselves in some way in terms of their own position. And so there's a lot of fear tied in. So we really need to understand what's happening for individuals there. And one of the key things when we were doing the active inquiry and the workshop was, where's the location of power? We had a woman who needed to sign a document. So she holds the power. She needs to sign it. Without her signing it, we don't move on. Does the document hold the power? Because it must be signed. Is it the thing with the power? Does the medical staff hold the authority on this has to happen? Is the woman midwife advocating for the woman? Where are the policies? They just rule everything. But ultimately, in all of that discussion, everybody in those scenarios ultimately said we all feel a bit powerless. So power is really important. And so I want to just look at some of the quotes that we came up there. So women say that they do know English and that they don't need an interpreter, and actually they do. And a kind of half understanding is actually much worse than no understanding. That was one of the interpreter's experiences. Another interpreter said that the women might do, by the way, I'm not going to do what they say, you know, that's ridiculous. You can't just communicate this to me. I can't help you. I'm the interpreter. So the woman's saying, I'm not going to do this, and the interpreter's in a compromised situation. And a woman saying, I don't know what you're saying, but I'm going to say yes anyway, because I don't want to look stupid. So those are some of the key things. The legal and ethical. You're going to talk about this, Şebnem.
This is something that kind of came up at various stages during especially the workshops. The distinction between consent as a legal requirement, because you cannot proceed without, for instance, written consent. If you are going for an emergency cesarean section, you cannot proceed without receiving this legal consent signed by the birthing person or the mother, versus consent as an ethical concern. Does this person understand everything? Have we been able to give all the information we could give before they said yes to this process or procedure? So there is the issue of urgency, which adds to the tension, and it becomes less about ethics and more about necessity. And this is the kind of gray area where trying to get informed consent can turn into a form of coercion. And this is not only limited to, of course, people with limited English proficiency in our case. It is a common situation. Even if you are speaking English, if there is this urgency, then you might be tempted to just sign the document and get on with it. So we talked a bit during the research about consent as a feeling. Do the people feel that they were respected, that they were involved in the decision making? And this situation is obviously just compounded for parents with limited English proficiency. So one quote in this case from a midwife, she was saying that you are trying to manage the person that doesn't understand, that wants to know everything because they don't know what's happening to them. And it's really difficult to get that point across. The point being, all you need to do is just sign it because we need to move on. And from an interpreter point of view, I don't know what it is saying, but I need to move on because the interpreter was saying this from the mother's point of view. I don't know what it's saying, but I need to move on because for the sake of myself and my unborn child, for safety, this has to happen. Sign it and move on. So here you can see that informed consent becomes something more legal than ethical. So in terms of building up a conceptual framework, which I think we're still in the process of doing, the questions that we put out right at the start, which stage is potentially the most complex? And actually what we identified was at all stages, but some of the issues vary. So in antenatally, the booking appointment can be quite complex and long, and we're trying to gather all that information, and that's a lot to take on board through interpretation. Then you've got the urgency and the immediacy of labour and birth processes. And in postnatal, particularly day 5, when there's, the baby's being weighed, we're looking at heel prick tests. There's a lot of information, again, to take on and screen for during that stage as well. Things that help and hinder, we're already hearing about continuity.
preparation. We talked about antenatal preparation. How much information can we prepare for in advance so that during labour and birth or postnatal periods, we're not having to start from scratch giving this information when it's all needing to be dealt with. That cultural awareness or a lack of that really hinders the way in which we can totally be present to these individuals that we're working with. And the total lack of resources. There is a dearth of resources in many, many aspects. Use of technology, again, that's coming up as something that has real potential, but it needs to be well resourced, it needs to be maintained and updated, and it needs to be thought out so that it's actually relevant and of use. And the legal and ethical aspects we're looking at, they're distinct, but they are quite interdependent, and there's a lot of complexity there.
Just to sum up the implications of this project and any actions may be needed, I feel that we are still at, I feel sometimes we are just scratching the surface. So I don't feel like we are at a stage where we can say, okay, these are the implications, this is what needs to be done. But just to conclude our findings so far, obviously raising awareness of the centrality of informed consent in these situations, and stressing the importance of empowerment of mothers and parents, necessity of collaboration, understanding that this is a teamwork for all the parties involved, and there should be some equality and shared power if possible in this teamwork. So more campaigning for continuity of care, both for midwives and for interpreters if possible. Quality training and regulation of interpreters so that they will have more accountability in situations that are particularly complex. Improved access to antenatal education for parents with limited English proficiency. Ensuring that there's a range of resources in various formats, so not relying totally on written leaflets, but also ensuring that there is visual and audio information available. Appropriate birth preparation, ideally one-to-one individual, even though we know how difficult it is. Use of bilingual, multilingual women who have had births in the UK and who can interpret and act maybe as doulas to women coming from the same ethnic and cultural backgrounds, but who may not necessarily have English yet. So we refer to them as interpreting doulas. And prioritizing time, both for education, antenatally, and also talking, reflecting, thinking before making a decision. Thank you very much for listening.